should 65 still be universal, or the MAP challenge, what we could see in the Andromeda-2, improved CRT in nearly half of the hypertensive patients? So does it say we should individualize MAP in hypertensive rather than using a blanket 65 target?
It's an interesting question, and you're aware of the UpPress trial that was published recently in ICM,
Yes.
in which a high MAP had deleterious effects and brought an increase in mortality. So I think that when initial resuscitation fails to improve tissue perfusion, testing for 1 hour helps us check if there is a positive response. And we showed in a trial that in an observational study, we saw the effect of this increasing MAP into capillary fill time, and there were some patients that improved and others that worsened. And it was similar to what Professor Dubin showed by increasing MAP and checking the microcirculation under the tongue in 2009 in critical care. And he showed that there was an heterogeneity of response. So this time frame of 1 hour allows you to check if the intervention helps tissue perfusion. If it doesn't, you can go back, so you don't expose patients to inappropriate catecholamines. So I think that's the beauty of this test.
So were certain phenotypes early versus late responders? Could you identify those? And is phenotype-guided resuscitation the next frontier?
That's an amazing question, and we just received the database, so we're starting to scramble around the numbers and checking the results for this kind of questions. So I hope that we can have a let's say if the hypovolemic responded earlier, or those with cardiac dysfunction were the worst. So we're addressing
hypertensive patient with the late responders, where you had to get the mean up further.
Yeah, those are amazing aspects that we should address, and it's a lot of work we're going to have this 2026 to bring up these clues. And regarding phenotypization, yesterday or the day before yesterday, there was a nice paper in JAMA published, the ImmunoCEP trial, that also was positive, and they were targeting molecular targets for immunoparalysis or cytokine storm, that also in the same line of phenotyping, trying to tailor therapy and trying to tackle this issue that septic shock patients as well as ARDS, there's a big bag of heterogeneity. So if we understand better the subphenotypes or the clusters, we probably will give more rational therapies.
So in recent time, I always say it's an era where initially we used to proudly say my ICU is protocolized ICU. Now we are moving towards where I say my ICU is no more protocolized. It's a personalized ICU. It varies from patient to patient. So we're coming there nearly.